Hey, everybody. We're so excited to have Dr. Shankar Siva here. He's given permission for us to call him Shankar. So welcome, Shankar. This is the ARRO Visiting Professor Seminar Series, SABR for Primary Renal Cell Carcinoma. So I'm Abhishek Kumar. I'm the ARRO Junior Chair of Communications. And we have Dakim Gaines. He's the ARRO Senior Chair of Global Health, and it's a joint partnership. We approached Shankar at Astro in San Antonio because we're really just inspired by some of the work he's done introducing SBRT or SABR, depending on where you're from, to primary renal cell carcinoma. So thank you so much, Shankar, for coming. Just by way of introduction, Dr. Shankar Siva is a radiation oncologist and current Cancer Council Victoria Colbatch Fellow. He leads the SABR program at the Peter Mac and is internationally recognized for his work in high-tech radiation delivery. He completed his PhD with the Molecular Radiation Biology Laboratory, focusing on translational investigations in precision high-dose lung radiotherapy. And he's certainly a leader in the field, and we're very, very thrilled to have him on. So thank you so much for joining and sharing your time. And good morning for you. I guess it's the next morning for you.
Absolutely, it's morning time. Thank you so much for the invitation. I'm genuinely excited, and thanks Abhishek and Dakim for inviting me to give you a presentation today. The brief was trying to make it a bit applicable to the residency audience. So we'll start with some background and then we'll move on to some more of the practical side of things. So the title is, for us, SABR for Primary RCC. And one thing that we've always known is that, at least during my training, and I think it's still currently the case in radiation oncology, is that renal cell carcinoma is thought to be radiation resistant. The reason for this is actually arising from 7 randomized trials that looked at treating patients post-operatively with external beam radiotherapy. The results of those studies showed that there was no improvement in survival. There was a reduction in locoregional failure, but the treatments were quite morbid. These were studies that were coming out in the 80s and 90s. And you can imagine that radiotherapy back then, and this is just a 2-dimensional image of a 3D plan, the radiotherapy at that time could be quite toxic. The small bowel falls into the nephrectomy renal bed, and the radiotherapy itself, being very imprecise, could lead to a lot of GI toxicities. Radiotherapy fell out of favor in the context of renal cell carcinoma, but I think in the new era, when we're talking about stereotactic body radiotherapy, SBRT, or SABR, there are different mechanisms of cell kill that we can recognize with high-dose radiation. It's important to know that high-dose radiation has other effects that are not just mitotic catastrophe and DNA damage repair issues. We're talking about endothelial cell apoptosis, ceramide and sphingomyelinase-induced cell death, which is an immunogenic signaling pathway, and pro-inflammatory cytokine release, which all are part of this ablative radiation approach. I think probably the work that I'm proudest of at the moment, and some of the work that's just recently come out, is from the International Radiosurgery Oncology Consortium for the Kidney, or iROK. We've just recently presented this data at Astro in last year, and has been published in November of last year in Lancet Oncology. This was a multi-institutional study that involved 12 institutions and had 190 patients with a significant long-term follow-up in the context of a relatively new treatment technique with the median follow-up of 5 years. Now, some things to note about the population that we tend to see with SBRT for primary kidney cancer. One is that the age is older than standard. So typically, the average age for primary renal cell carcinoma that presents to surgery is in the mid-60s. In our early 60s, in our cohort, the average age was 74. There was good performance status in this group. Most of the patients that were referred were medically inoperable, about 3/4 of the patients that were evaluable from that perspective. Pathological confirmation was high. So one thing that thermal ablation colleagues or interventional oncology colleagues will say that, yes, we can get biopsy and treat at the same time, but actually that's quite rare. They actually need 2 separate different types of approaches, typically different port tracks, and the rates of pathological confirmation in the thermal ablation series are typically lower than what we are reporting here. The maximum tumor dimension is also larger than is typically reported in thermal ablation approaches at 4.2 centimeters. Typically, thermal ablation series are in the 2 centimeter mark to 3 centimeter mark. And quite a proportion of patients had a solitary kidney, which is of interest, and we can get back to that. And the biological equivalent dose, there's quite a broad range in this series. So the headline results of the series that was just recently published is that at 5 years, the cancer-specific survival was 92%. There's only a few rates of grade 1 to 2 toxicity, and no patients were suffering grade 3 toxicities. There was one patient who had both a grade 4 gastritis and grade 4 bowel toxicity, and this patient was alive 8.8 years later without evidence disease. Local control, the failure rates on a cumulative incidence graph is 5.5% at 5 years, and for distant failure, almost 11% at 5 years. So from a renal function perspective, this is important too. When we're talking about nephron-sparing options, the trifecta that urologists talk about are oncological outcomes, complication rates, and renal function. From a renal function perspective, this is a cohort that we treat that is typically has much worse renal function than we see from our thermal ablation or surgical colleagues. So the average renal function here is 59 mils per minute, which is chronic kidney disease class 3 already. And despite this, the loss of GFR is relatively modest. At 1 year, it's 7.2 mils. At 3 years, that's the peak period where it loses between 1 and 2 years. It's 10 mils, and at the longer time points, about 13 mils. So it tends to plateau at a later time point. Only 3.7% of the group underwent dialysis, and this group all had a lower GFR rate. So the average GFR in the group that underwent dialysis was 28.1 mils. The tumour size is an important consideration. So half the patients had tumours that were T1A or smaller than 4 centimetres, and the median size for that group was 2.84 centimetres. This is consistent with what we see in the thermal ablation literature. And about half the patients had tumours greater than T1B, and the average size in this group was 4.8 centimetres. Tumour size was associated with reduced cancer-specific survival and progression-free survival. When we split it by T1A and T1B, there wasn't a statistically significant difference between the two groups in terms of cancer-specific survival or local failure. An intriguing aspect of that study is that quite a lot of the patients in this iROK cohort received single fraction SABR, most commonly between 25 gray to 26 gray. Single fraction SABR was associated with the reduced risk of local failure and reduced risk of progression. And on multivariable analysis, local failure was still significantly higher for those patients receiving multi-fraction SABR, and quite a large hazard ratio at 6.1. So that's quite intriguing. It's something that needs to be reproduced in a larger trial. So just in a summary, we observed 5-year local failure rates of 5.5% in a large series of about 190 patients with larger renal masses than is typically for thermal ablation. These outcomes with these modalities, despite having a larger size, were similar to what we see in comparison to partial nephrectomy, radiofrequency ablation, and cryoablation, which is typically between 95 and 97%. And also in the population with pre-existing chronic kidney disease, we saw a clinically acceptable decline of 5 years by a mean loss of 13 mils per minute of eGFR. Just in terms of consistency, we did perform a systematic review in 2019 as our group, and we published this in European Urology Focus. It's consistent to what we see across the literature. The local control rate when pooling this in a meta-analysis was 97.2% across the studies. Having said that, a lot of these studies were retrospective in nature. You can see at the top there's a few studies that were reporting lower local control rates, and these were very large tumours and typically in the context of metastatic disease. So in other words, cytoreductive treatments. So some of the practical aspects we need to consider is kidney motion. And this is something that is a common question when implementing SABR in a program. This is, I think, meant to be a donated kidney or a kidney that's donated kidney and getting cash for it. But kidney motion is a serious issue. And one of the things that we see on 4-dimensional CT imaging is that the kidney is quite a mobile organ. It clearly moves with the diaphragmatic motion. However, when we first started our program, we actually went through the exercise of looking at consecutive patients having 4D CT for other reasons. So these patients had normal kidneys. And the average displacement on the left and the right kidney was 3/4 of a centimetre. So most patients, in fact, probably won't benefit from a motion management technique. However, there were some extreme outliers, and these were patients who had maximum amplitudes between 2.3 centimetres and 3.3 centimetres. And those are the patients that you need to pick up front and consider for a more robust motion management approach. And again, this is consistent with the literature. When we looked at what this looked like on a review of the literature, there have been 25 prior publications to that study, and 15 of the studies reported free breathing, and the majority are reporting an average motion of less than 10 millimeters. So this is consistent not just at our institution, but across the literature. Another particularly important aspect from a practical perspective is to keep the kidney function happy. And that's one of the trifecta I mentioned from a urological perspective. Nephron sparing is a key component of these approaches. Initially, when we opened our program, we did do nuclear medicine functional assessment of kidney excretion of a tracer called technetium 99, and we did two different aspects. One, which is I'll speak about in a second, but the second one was DMSA spec CT. So what this tracer allows us to do is see the renal function as excreted through the nephrons in the renal cortex. So this is a patient, an example, who had a single solitary functional kidney that was treated with a single fraction of 26 Gray to the endophytic mid-pole tumor. And what's demonstrable is that in the first early period, at least up to 3 months down the track, there doesn't seem to be an appreciable loss of renal tracer excretion through the cortex. However, in the longer time period, between roughly a year and even further down the track, we can see loss of kidney function within the high dose regions that the radiotherapy was delivered in. This is actually consistent with our first cohort when we produced our first study, which is called Fast Track. We had an eGFR baseline of 55 mils per minute. Importantly, sorry, I should say this is a calculated GFR. This is chromium-51 EDTA calculated GFR, the gold standard assessment for a nuclear medicine assessment for GFR. It's like a 4-hour assessment where the patient has to be in the nuclear medicine department. Still, the patients had pre-existing chronic kidney disease. This is consistent with the recent iROK publication at 55 mils per minute. And again, consistent loss of renal function at 1 year by 11 mils, and that was stable at 2 years. But with these images, we can see that this patient who has a large lower pole kidney tumor has very dose-dependent loss of kidney function. There's a big bite out of the area of that lower kidney in terms of renal excretion in the cortex that is evident after 3 months. So what does that mean, and how is that practical? So when we actually compared the dose-response relationship amongst the cohort from that initial prospective trial, our physicists were able to come up with a formula that described both a single fraction of 26 Gray and 42 Gray in 3 fractions. And biologically, when converting to a biological effective dose, it has a very similar pattern. The take home from this message is that supralethal doses are observed when you have a biological effective dose of above 100 Gray. So really that high dose area that's delivered immediately around the tumor, anything in that area is really going to have the same effects, a loss of kidney function. The best area to spare and to be able to have the greatest gains in improving kidney function or reducing the loss of kidney function is that intermediate dose, a less than 100 Gray biological effective dose. So if you can keep that intermediate dose wash really tight, that's going to help with kidney function down the track. And the third thing I wanted to touch about was the challenges in kidney SABR, and that's about response assessment. One thing you'll notice during your program is that kidney tumors take a long time to grow, and again, they take a long time to shrink. So this is an example from 2 different institutions, one on the left from the USA and one from the right from Japan, that shows that patients were tipping into what we would call RECIST criteria of partial response, even several years down the track. So these are examples in 2 years, 3 years, 4 years down the track where they tip into a partial response. And often what is used in the use of small renal masses is contrast enhancement characteristics. And that's really not useful in the context of SABR. This was a very elegant study published in 2016, looked at patients receiving SABR and looked at the change in tumor size on a waterfall plot on the left, where the majority of patients had reduction or stability in the tumor. They reported 92% local control. On the right-hand side is contrast enhancement characteristics on CT. So common descriptions are CM, which is corticomedullary phase, EN, which is early nephrogenic phase, and LN, which is late nephrogenic phase. And pre-treatment, the black line, post-treatment, all of these contrast enhancement characteristics actually get higher post-treatment. They don't reduce because thermal ablation is a physically destructive technique. Radiation is not. And in fact, vascular permeability actually increases post-treatment. And we can't use contrast enhancement as an approach to assess response. A perfect example of where we get some of these issues is a patient of mine that we treated with the 26-grain single fraction approach for a mid-pole exophytic tumor. That's a baseline tumor in the top left and middle left. And 5 years post-treatment, we can see there's a bit of a renal carcass there. There's less cellular density. And 7 years, it's consistent too. But if you're a radiologist and you put a caliper measurement from the maximal dimension from one end to the other, it would look like it's exactly the same size as it was at baseline. And these are some of the issues we face when we're trying to assess response using purely measurement-based criteria or even contrast enhancement. So I promised the team here that we'd talk about just some general aspects of setting up a kidney SBRT program.
Actually, Shankar, can I ask a question about some of what you said? Thanks for sharing all that. It's very interesting. So I have a few questions about what you mentioned, and Dakim, feel free to ask questions too. The first question is, when you see an exophytic lesion like that, do you feel like that patient's going to have less of a GFR decline than any endophytic lesion just because of parenchyma being spared?
Yeah, absolutely. I think dose matters. So the location of the tumor will also matter as to how much, in particular, the intermediate dose is going to be splashed around the rest of the kidney. So exophytic tumors are ideal. Even more ideal is very lower pole tumors on the kidneys or upper pole tumors. So my favorite spot, if I have to pick a favorite spot, would be the right kidney, right at the apex and exophytic, because the liver is sitting right next to that area. There's very other few organs at rest. The bowel's not an issue in that area. And that's a great location for us.
Yeah, thanks for answering that. I didn't realize the kind of the nuance in the first graph that you showed that we're treating, or you're able to treat tumors larger than, say, our IR colleagues are able to handle. But then also I had a question about your fractionation. I know you do a lot of single fractionation. Do you ever do more than 3? Are you ever doing like 5 fraction or 8 fraction regimens?
That's a good question. So just in reference to your first comment, yes, absolutely. The small renal mass is something that we are equivalent, in my belief, to thermal ablation, but we have a great advantage, and the real niche and sweet spot is those patients who have T1B tumors or even tumors above 3 centimeters, 3.5 centimeters. Thermal ablation, the efficacy drops off rapidly after 3 to 3.5 centimeters, and also based on location. Endophytic tumors that are near the renal medulla or the draining tracts, they have issues because that kind of endophytic area that's near the renal pelvis has a lot of blood vessels that act as heat sinks that actually draw away thermal energy. The ureter is also a risky area for cryoablation, thermal ablation, microwave, because the ureter can have strictures post-therapy, which is not something that we see with SABR. So there are some unique competitive advantages as we have at radiation. The second question, I think, and I've forgotten, unfortunately, Dakim, do you mind repeating that?
Yeah, no worries. It was about fractionation. I know you do a lot of single, but do you do like anything like 5 or 8 that's more multi-fraction than 3?
So the short answer is we do participate in the CytoShrink study, which is a study that's been promoted from the Canadian group, OCOG. So in that study, we do 5 fractions, and that's the only time. That's in the context of cytoreductive cytoreductive SABR during IPI-NEVO. Everything else is either single fraction or 3 fraction. That program was established really early. We've stuck with it, got great results. I actually think theoretically, it makes a lot of sense because renal cell carcinoma has a very low alpha beta ratio. It's about 2.6. The other, potential one is 6.9, but typically it's around that 3 mark. And when you have a tumor that's within the kidney parenchyma, which has a higher alpha beta ratio, you've got this biological advantage by giving a big dose per fraction. Whatever you ablate is going to be ablated, but it's the tissue around it. So the normal kidney parenchyma, if you take 50% of 26 gray in 1 fraction, that's 13 gray. And total dose matters when you have a high alpha beta ratio. So that's only 13 gray that's going to normal kidney parenchyma. If you take 50% of 40 gray in 5 fractions, for example, we're talking about 20 gray to a large volume of the kidney. And that's going to do more damage from a renal function perspective. So there's kind of this unique area that not only does RCC respond really beautifully to high dose per fraction, I think the kidney parenchyma is also going to be spared by doing that approach.
So one more question before we can continue on with your presentation. You looking at your the iROK, which is a great name, by the way. Every time you say it, it's like self-affirming. iROK, just great. You did a multivariable analysis controlling for size. So I'm trying to understand, are there any other factors that are, maybe residual unmeasured confounding that may indicate that a patient who's getting 1 fraction versus 3 has a different outcome? Because you're controlling for size, which in my head, I was thinking, okay, maybe smaller tumors are going to get, single fraction. Is there any sort of like proximity to bowel or anything else that may make it more risky to do the treatment, or anything you could speak to about that?
Yeah, so we did, to be honest, I took a very deep dive into the data because I wanted to make sure it was 100% robust before presenting it because I didn't believe it, to be honest. But we controlled for in the multivariable analysis for multiple factors, including size, age, performance status. There's a few other things, solitary kidney versus bilateral kidneys. So all of those factors should have fallen out of the analysis. The groups are unbalanced from single fraction and multi-fraction. The patients are a little bit younger, and I think the tumors were a little bit smaller too. So it's not 100% accurate or robust in the sense that we can definitively call that the case. But to the best of our knowledge, that finding is true. The only way to be able to confirm this is to directly randomize single fraction versus multi-fraction. And that is something that I would like to achieve before, in the next 10 years. And then is there a maximum size tumor that you wouldn't do single or double fraction, single fraction or multi-fraction to? Yeah, good question. It's been, yes, we started off actually a bit higher. So the tumors were greater than up to 5 centimeters we're treating. The only reason I've switched over for about the last 5 years to 4 centimeters as the maximum size for single fraction is that simply it's a unique competitive advantage against thermal ablation. If you think about it, thermal ablation has the advantage that it's a single session that a patient comes in, but it's still invasive. Whereas for us, we can do non-invasive and single session as well. But thermal ablation is really not a good option for tumors that are greater than 4 centimeters. And so it's very simple for us to do single fraction for tumors less than 4 centimeters. And for above 4 centimeters, I think we've always stuck with that 3 fractions, 3 by 14 gray. So yeah, I think roughly speaking, small renal mass is single fraction and larger renal mass is multi-fraction up to 3. Well, thank you for answering all those. We'll let you go ahead and continue your awesome presentation. Thank you. So this is a bit more ad hoc and ad lib. I have not ever presented this kind of stuff before, but I thought I'd talk about the kidney program and setting it up. And obviously this is just my experience and just my thought bubbles. So it's not reflective of, it's also reflective of being in a different country and probably a different environment. But nevertheless, let me just talk to you about how I got to this point, which is basically my first year as junior faculty. One of my mentors, who is the head of our GU radiation oncology group at the time, asked me to investigate SBRT for primary kidney cancer. So we took it in a very stepwise manner, one which is a literature review and then subsequently a systematic review. And I think that step actually for those academically minded is a really important step. You're going to have to do a literature review anyway for any kind of clinical trial protocol. might as well make it as robust as possible and get something out of it at the same time. So that process of doing a systematic review was very helpful. It also informed the fact that a lot of the studies in the past were single fraction, so that's something that was informing our protocol. At the time, though, I did a clinicaltrials.gov search, and there's a graveyard of prospective trials. There's a whole bunch that were open, failed to recruit, closed due to early recruitment. And I thought my mentor was mad to try to put me into this box to try to get the study started. Nevertheless, did persist, and through, as most studies do, just having a little bit of seed funding through a small competitive grant really oiled the wheels and got everything moving. So this was a small grant of less than $50,000, but this allowed us to be able to at least start a protocol and write a protocol and commence a early in-house clinical trial. This was further funded because you leverage from further funding through a larger grant body. And this allowed us to recruit from 2012 to 2014, 33 patients in a single institutional study. So I think that's a pretty rapid recruitment rate and that probably shows that the interest of being able to have something new and novel to give as an option to your urological colleagues and genitourinary colleagues was really jumped upon and embraced. So after we established, that really allowed us to establish a program, made it very protocolized. We followed all our data really closely. That initial publication was in 2017. And towards that time of 2017, 2015 area, I developed a prospective multi-institutional study called the Trans-Tasman Radiation Oncology Group, which is TROG, the 1503 code, which denotes it was designed and approved in 2015. So that was approved. It still took multiple rounds of national competitive grant funding to try to actually get it funded, even though I thought it was a good idea. Grant bodies didn't necessarily think it was. And finally, we got activated in 2017. Took 3 rounds over 3 years to get it funded. Around that time as well, I noticed that there was not a really coherent or approach to treating primary kidney cancer. And I noticed there had been quite a few publications prior to this that were very disparate in terms of timeline. Some were as early as 1995, and some were as late at that time point as 2013. So I did reach out to a lot of the investigators that had already published prospective phase 1, phase 2 data in the space, and they were all very receptive. So reaching out to principal investigators is always going to be a good idea. I think very few of them are not willing to collaborate. And we set up the International Radiation Oncology Consortium, so iROK. This was 8 centers at the time. It's grown since that time point. But by organizing a group, we were able to actually leverage the group intelligence, send out a consensus statement, and be able to harmonize approaches. And that really set off the subsequent collaborations. Other things you really need to be focusing on is talking to the surgeons, because these are the gatekeepers of primary renal cell carcinoma. We have no business in this space, or at least we didn't until the last 10 or so years. And still, there's a lot of degree of suspicion still from maybe community urologists who are not aware of some of the emerging data. So the way to approach from my perspective was to be really non-threatening. The initial study was really not about replacing or competing for RCC. In fact, surgery is still the gold standard. But the option is to really talk about those patients who are not ideal operative candidates, who may be technically at high risk for dialysis, medically inoperable, or really pose challenging surgical cases because of comorbidities or body habitus. And this type of approach is, hey, you know, we have this other non-invasive option, maybe we should consider it. The other question is our interventional radiology colleagues. So depending on where you are, these groups can be very strong or less aggressive. The way in our institution was really to engage with the surgeons, not the interventional radiologists, partially because they don't tend to follow up their patients, whereas we in Renal do. I think that's a big bonus from a urologist perspective, because it means they can safely hand over a patient to our care and know that we'll follow them up for the next, in my case, 5 years or plus. So talking to the urologist, didn't really try very hard engaging with the interventional oncology team, and I think that's probably a good way to go. The interventional radiologists in our team are actually very conducive and very receptive, and now we have a really great working relationship. I just don't think they were a key player in the process. Try and tie a research aspect to encourage referrals. This is really important as well, because I think by having some kind of research aspect, a trial ideally, but even a registry or a database, that really encourages the idea of some kind of academic process that surrounds the program and will probably encourage referrals. So one aspect, and maybe this is a shameless plug, iROK is setting up a prospective registry. We have 30 institutions that are currently enrolling. We've only got one over the line so far from governance, but we expect over the next year or two, there'll be up to 30 next year. And this will be a prospective registry that's designed in REDCap. So if you are interested and have a program running, please do reach out and we can add you to the registry. Be prepared for really unfavorable cases initially. Some of the cases we were seeing were ridiculous at the start. So it's useful to have some kind of protocol and cap. Initially, we had a cap at the 8 centimeter maximum dimension of tumors. And for those patients that were primary only, not metastatic. This has been relaxed a little bit. Now we're up to 10 centimeters in general. And for the metastatic cases, there is no size limit. But some of the caps you can potentially put up front will help you make sure that you don't have a major complication up front and have the program shut down really early. Interact if you can on a regional level, and this is important for both multidisciplinary meetings and scientific meetings, and aim to be the center of excellence if you can. I might pause there if there are any more questions, because otherwise I'll move into some practical cases.
I have many questions, but I'll try to keep them short. I guess from a ablation standpoint, I think a lot of what you're saying reminds me of how we treat hepatocellular carcinoma, and where you have surgery colleagues, you have interventional radiology colleagues, and then we have SBRT that is more of an emerging type modality. Is there any patient that you feel like thermal ablation may be more conducive to control or to renal toxicity than SBRT?
Yes. So I think that those patients who have really small tumors that are exophytic, and when I say small, 2 centimeters or less, that's probably best treated with thermal ablation. It's easy. And also, for us with motion management, we might be treating a larger area of the normal kidney parenchyma than they will. And the outcomes are going to be excellent. So I think they already have an established role in that space. And to be honest, I think outcomes, whether it be active surveillance, surgery, or SABR, or thermal ablation in that setting, they're all going to be great. So it's not really that interesting a group from my perspective anyway. I don't think we're adding too much to the table there. So it's probably that kind of small exophytic tumor that I think we can probably let our thermal ablation colleagues deal with.
And I just had a follow-up question. At any point when you were building your program, did you feel like the push? So you mentioned that it's really non-competitive for the urologist, but I feel like maybe the interventional radiologist may view us as competing with them. How were you able to kind of dodge those barriers?
So it is going to be very specific to your own institution and your environment. Personally, I can only speak from my own experience. We did treat predominantly the larger renal masses initially, because obviously those are the ones that have no alternative option, patients who are not medically operable and have tumors that are not suitable for, or maybe at risk of dialysis with a nephrectomy because they're endophytic and no partial nephrectomy is an option. In fact, many centers, depending where you are, don't even perform that many partial nephrectomies. So that's something to consider as well. So we had larger tumors, very endophytic, very complex tumors at the start. And I think that's a unique opportunity. That's probably the group that you want to start with. If you can show that to your colleagues that you have a demonstrably more acceptable and quite effective treatment compared to the alternatives, then that's really going to get a lot of encourage a lot of confidence in the approach.
Now you've presented some really compelling data. The local control is like an A+, 95+%, with very little renal decline, very little incidence of patients needed dialysis. What are the criticisms you're still hearing from colleagues from other specialties, or even from our own, about the role of SABR and primary RCC?
So I think the most common, perhaps it's not a criticism, I think to be honest, I think the urologic community is starting to embrace this approach. The NCCN guidelines have SABR for primary RCC, SBRT for primary RCC. The EAU guidelines hopefully will actually adopt it as well. We've got other guidelines in a few different other sections that have also adopted the approach. So I think things are coming around from that perspective. But the most common, maybe not criticism, but question that we get from a urology point of view is that we don't have pathological confirmation of the tumor being ablated or treated. So, for example, I've told you some of the issues about response assessment techniques. Really, time is the best response assessment tool, and that's why we need to follow these patients up for a long time. But often urologists expect that there'll be post-treatment tissue. That's maybe from their experience from thermal ablation, for example. So the idea of a tumor, post-treatment tumor biopsy, I cannot discourage that enough. It is really a false premise, in my opinion. The idea that we need to be proving that there's no viable tissue, we've stopped doing that across cancer types 20 years ago. So they used to obviously probably recall the times where we used to do routine post-head and neck dissections after radiotherapy for nodal disease. We used to do cervical cancer, nodal clearances and post-operative surgery. Even in the prostate, we used to do post-radiotherapy biopsies. Now, that's clearly shown time and time again that post-treatment biopsy cells do not represent viability and likelihood of local control in the long term. So, when someone raises that as an issue, it's really important to say that, you don't agree with the premise of the question. It's never been the case that radiotherapy post-treatment biopsy is consistent with local control. And, our data speaks for itself in terms of long-term control rates.
And then for patients getting surveillance, you mentioned, larger tumors that may not be amenable to thermal ablation. Of course, like surgery, and I think partial nephrectomy, even over radical nephrectomy, is the gold standard. I guess both surgeries could be gold standard. Are there patients that you feel like can benefit from SABR who are in the surveillance group?
Yeah, that's a good question. So there was an NCCN, or I think NCDB, I can't remember which database analysis, that looked at patients who were elderly, so above 70 years old, who had underwent active surveillance versus those who had some kind of intervention. The intervention wasn't SBRT in this case because it was an earlier study. Only a very few patients actually had SBRT. But that showed there was an association with the intervention and improved oncological outcomes and survival outcomes, as opposed to active surveillance in the elderly population. So I think age is not a barrier for intervention. So that's one thing that we should be advocating for. It's more about the oncological scenario. So often the cases in patients who are comorbid will undergo a period of active surveillance. And I think that's very clinically acceptable when they have small renal masses. The issue is when patients get to the growth rate that's greater than 5 millimeters in 6 months, or a tumor size that's greater than 3 centimeters. Those tumors go from having pretty much a negligible metastatic potential of less than 1% per annum to actually having higher metastatic potentials. And those are the patients that you should be focusing on in terms of having an intervention in the forms of non-invasive radiotherapy or stereotactic radiation. I work in an institution that has a very high quality and high throughput robotic partial nephrectomy service, excellent surgeons, and they also have high volume. That's actually helpful. Having good surgeons that are confident in their techniques also means that they're limited and know their limitations too, and probably will look for options when they may not be that favorable from a complexity perspective. So the renal score for example, is one metric for assessing complexity. Those are endophytic tumors that are not really amenable to partial ablation. The conversations now turn to, why don't we do SABR first, and then we can potentially think about an nephrectomy down the track if it doesn't work.
Amazing. Thank you. Why don't you continue with your with the end of your presentation?
Sure, and just pause it. Let me know when we're running short on time. Interrupt, please. So this is a case. It's a 76-year-old man with a serially enlarging right mid-pole mass. So in other words, period of active surveillance initially, but had been enlarging. Now it's 5 centimeters in size with a growth rate of greater than 1 centimeter per annum. Has some comorbidities, the classic type of patient we see with pre-existing chronic kidney disease, some obesity and ischemic heart disease. Discussed at the multidisciplinary meeting, and with the patient, he's keen for active treatment now that it's getting to a point where we can potentially see metastatic potential. It's a good location for us from an SBRT perspective. It's posteriorly located. There's no bowel close by. It is endophytic, so there's going to be a bit of renal parenchyma treated, but for us, pretty good location. So biopsy confirmed clear cell renal cell carcinoma and staging is clear. I think that's one thing that I've been very conscious about. We didn't mention it. Biopsy confirmation, I think, is really important if you can. We have a new modality of treatment for patients with primary kidney cancer. The onus of proof, the burden of proof is with us. And if we're treating lesions that our colleagues can turn around and criticize us, that could have been a benign oncocytoma, you don't really know your outcomes. We don't want that criticism. That's an active discussion point in the non-small cell lung cancer space. And certainly for kidney cancer, I think it's preferable to try to get a biopsy before treatment. From our perspective at PEDMAC, it's really quite simple. We do for free breathing 4D CT. Our preferred immobilization is dual vacuum immobilization, but even then, that's not 100% necessary. We do find that does reduce a bit of motion. But you can use your own technique from your own institution. Putting it in context, of very first studies, we're using 3D conformal radiotherapy with non-coplanar techniques, and that was in 2012. So simple techniques work. Obviously, the better technology and immobilization you can do, the better. But know your limitations, know your IGRT, be aware of artifacts and missing information. So this is the patient at 4D CT. A couple of things to note. It is a moving target. And when we go to the time of actually contouring this, that's the tumor just on a single phase. When we look at inspiration phase, you can see that the tumor's heading downwards. And there is motion encompassing, need to encompass all that area. And this is the bottom area of the tumor. Now, one thing is there's artifact to this bottom area. So it's really important at this point to consult with your physicist and make sure that artifact is not affecting the tumor, the area of the tumor. It looks like it is. So in which case you may have to get rid of some of your 4D CT bends and contour in different phases. Anywho, this is the ITV approach when you combine a couple of phases and the tumor at the time of the cone beam CT. Now, depending on your technology, the cone beam CT we have on our machines, which is Varian, is not fantastic. So the image quality that you get at the time of machine, even on treatment, even at spotlight mode, is pretty limited. Nevertheless, you do your best you can using other surrogates in the area as well, including the normal kidney parenchyma. So for us, it's important if you're doing a free breathing, motion encompassing technique, you'd use ITV with the full exhale and inhale phases. And if you're using an ITV concept, don't rely on the maximum intensity projection or the average. Carefully go through each respiratory bins and understand any artifacts. Now, this also applies to organs at risk. So do pay attention to bowel contours and motion if it's really close to a high dose region. So this is an example of a tumor which has overlap with the ITV in the exhale phase. This is not something you'll necessarily see in the average phase where you're doing most of the contouring for organs at risk. But here, when we look particularly on the in the sagittal image, we can see that there is some overlap of the ITV in the small bowel. So this patient was replanned and actually treated in a an XL breath hold option instead. One thing that we have moved towards, which has been a real help in contour delineation, is the use of 4D CT with slow drip IV contrast. This is an example of slow drip IV contrast. You can see that it does slightly change the intensity of vessels, but it does really help the delineation of the actual tumor on the average in the 4D CT and the MIP of the 4D CT. So I think when possible, having some kind of an IV contrast protocol at time of sim, if the patient's EGFR is permissive, is very helpful. Now, if you can't do IV contrast, this is an example in a patient who had contrast allergy. Multiparametric MRI with the use of gadolinium can also be very helpful. And this is a much vast improvement of what we saw on the left-hand side, which is the 4D CT without contrast, as compared to potentially fusing this with a T2-weighted MRI sequence. And that was just the example of the patient before with replanning in a breath hold technique. Practical aspect, you can always use our protocol. It's online, it's published. These are all the dose constraints that are available there. I think the only difference that we do compared to this and to practice at my institution at this point is that we add a 3 millimeter PRV margin to all the hollow viscous. So the same dose constraints. These are pretty robust, some would call aggressive, and I think you do need to be aggressive. So these are pretty high dose constraints. We use 3 millimeters in a PRV to stomach, small bowel, and large bowel for both of these treatment options. What happens when the ITV abuts the large bowel? This is an example of a common location, right lower pole of the kidney and anteriorly located. That's a common area where the ascending colon becomes an issue. And this is an example if we have an ITV-based approach and using a 42 grade in 3 fraction approach, that we're getting large, even hotspots that are close to the large bowel. If you do observe this, it's really important to try to respect that large bowel and try to carve some dose away from that area. Our normal prescription in general is trying to cover the tumor quite tightly, but whenever we see an organ at risk, we carve away dose from that area. So an example is 42 grain 3 fractions, all the treatments at Peter Mac are the same. We aim for a coverage of D99 of greater than 100%, but compromise for bowel, in other words, down to 95% when necessary. Always heat up the center of the tumor. That's really important as well. Renal cell carcinoma loves high dose per fraction. So Dmax is somewhere between 125% to 143%. That's equivalent in the old school metric of a covering isodose of between 70 and 80%. Keep on the eye on the GTV and the ITV. So it needs to be a minimum dose of between 100 and 120%. The dose fall off, this is a metric that we do measure. So we try to keep the R50 or the 50% isodose to be 4 to 5 times the size of the PTV volume. And that really depends on the proximity to organs at risk. If you are carving dose away from one angle, then it means that your intermediate dose is going to blow out. We'll just try to avoid as much of that into the normal kidney parenchyma as possible. If you can, try for an isotopic fall off of the dose. So generally try to keep 50% within 2 centimeters, because this is going to give you the most conformal and most rapid dose fall off from the intermediate dose to the high dose area. And if pushing one or two dose gradients, particularly against bowel, you can drop that kind of constraint for the primary gradient to a shorter area. And yep, that's another thing, just to plug for the fast track dose constraint. They're publicly available, they're online, and just use a 3 millimeter PRV on the organs at risk. We can do a couple of cases just to give an example of what we do. So from a...
Can I ask a quick question?
Sure, yep.
If you had a preference versus breath hold or 4D, which one do you... It sounds like you do 4D preferably, is that right?
Yeah, we do, because I think breath hold from our institutional protocol also needs further assessment for the patient for the reproducibility. We often do a mock-up session to make sure that the patient can actually comply and reproduce. There's no baseline drift in the position of their exhale breath hold. So this all adds extra time and extra visits for the patient, well, one extra visit for the patient. So ideally for 3/4 of the cases, and that's still pretty consistent with what we're seeing both in the literature and what we're doing in practice, an ITV approach is perfectly fine for patients who have tumor motion of less than 10 millimeters in size. When we see tumor motion greater than 10 millimeters size, that's our threshold to try to consider either gated delivery of treatment or exhale breath hold. Exhale breath hold is more reproducible than inhale breath hold, and that's probably the preferred approach.
Thanks.
So an easy one, this is like a location that's perfect for us, posteriorly located away from bowel. This is really easy. We use a PTV D99 of 42 gray as per the fast track protocol, a Dmax of 136%. The 50% isodose, the R50 is 3.8 times the size of the PTV. And we're talking about the minimum dose of the GTV being pretty high again, 120% of 42 gray. This is 2 coplanar VMAT arcs, half arcs, 6 MV triple F. We can also use 10 MV triple F. And these are some of the doses that were delivered. The monos units that were delivered were 2100 monos units per fraction. And the time from the first cone beam CT to the last arc finishing for each treatment was 10 minutes. And that included 4 cone beam CTs for verification. So, really easy treatment, straightforward and short for the patient. Some of the not ideal approaches for intermediate dose spillage, you can see this is a patient that has what should be an ideal location for treatment, but there are some intermediate doses, which we're talking about the purple line and that light blue line, that are spilling out towards small bowel in particular, not so worried about large bowel, but small bowel in particular. Now that's unnecessary. There's no reason for that to be the case. The improved version of that same treatment plan is trying to pull back some of that intermediate dose. So unless in the optimizer, your dosimetrists are paying attention to where the intermediate dose is going, this will just splay out and you will get these intermediate dose horns heading in towards small bowel. And that's a tighter way of the same treatment prescription, same coverage, same everything else, just an improved placement of that intermediate dose. Cysts, you mentioned we have cysts in this case. This is an example of a cyst that's sitting right next to the area of treatment. This is the R50 isodose line, which is heading into the liver, and cysts on either side. We can really tighten that up. There's no reason for it to head that way unless your dosimetrists are keeping an eye on it. Then they're really not going to pay attention. You can just pull that in. And one other thing is we have a publicly available, I believe, knowledge-based planning approach for our treatment techniques that you can use. You're welcome to use that. So, if that helps, this is a knowledge-based planning replan based on that treatment approach. Maybe that's a time to actually ask about cysts. I know that was a point of interest.
Yes, I mean, I remember I've been thinking about cysts all week because we were actually, we're planning a case for RCC actually with SBRT, and this patient has lots of cysts. So we were wondering, is that when you see cysts, are you happy because you can do hot spots in the cyst and that's safe? And it's almost like this internal organic, spacer. Is there something you worry about? And then the part B of that question is, for our other strategies, our colleagues, like using thermal ablation, is there an advantage for SBRT with patients who have multicystic disease?
Yes, so great question. It's not that common a scenario in my personal practice, but it may be in others. But it does occur. So with cysts, first of all, they are not an issue from a radiotherapy perspective. They don't They don't pop or burst or anything like that as you would expect. That's a common question. Having said that, percutaneous ablation, this is an issue potentially with cysts, particularly if it's along the path length. So cysts can be sometimes difficult to biopsy, can be difficult to also be accessible for thermal ablation. So this is, again, a competitive advantage for where we are situated. I haven't really considered it as a natural spacer or a hydrogel or a buffer, because really the main goal for all my treatments is trying to be as conformal as possible, both the intermediate dose and the high dose. The high dose region is really easy to get conformal. It's the rest of it that's difficult. And so that's probably the aim of the treatment, to reduce the amount of treatment to the normal kidney parenchyma. So I pretty much ignore the rest of the normal cystic areas, and that doesn't really factor into the planning process at all. Some of the issues arise with the complex Bosniak tumors, which have a cystic and a solid component. The classical teaching is it's a solid component that has the potential malignant component potential and the potential to metastasize. So I don't go chasing the rest of the cyst. It's really targeting the solid component alone, but that introduces a lot of issues with image guidance. And so image guidance on cone beams are a challenge. I'd recommend delineating upfront as many of the cysts that you can, and delineating some adjacent image guidance structures that can help guide the actual treatment, because trying to target a partial area within a cyst during the cone beams and image verification can be a challenge.
Well, this is really, really awesome. So we thank you so much, Shankar. As residents, when we see, publications that your group had in Lancet Oncology about the role of SBRT, I think gets us excited, because we're training with a lot of SBRT, and seeing how well our patients do in treatment checks and even the short term is really great to see. And do you feel like you see the same for your patients, in long term, how they're doing?
Yeah, I mean, look, it's true. I think the clinics are getting longer because patients are living longer. So, back in the day, we used to have clinics full of patients that had high turnover, but now, we're following post-SBRT for early stage non-small cell lung cancer and kidney. They're 5 years out. So that's great. It's really promising from our perspective, but it means also that the workload's getting a bit heavier. But yes, absolutely. I'm a big advocate for SBRT, obviously, and I think that is the future of where we're going to go. The interesting spaces from my perspective are also advanced disease, how we integrate in there, and also combinations with systemic therapy, which we can talk about for a whole other hour some other time.
Yeah, thank you so much. Really lucky to have you give us some insight on a program you really brought from the ground up.
Thank you. Thanks for having me.